based in Bangkok, and also the co-chair with Rita. I can hand over to Zainab, who is our moderator for this session.
Good morning, good afternoon, and good evening. We're hosting this webinar from 3 different time zones. So I hope you are as excited as I am to learn from the different contexts. We have around 41 participants. That's a good number. My name is Zainab Shirri, and I have experience working with the Syrian refugee adolescent girls in Lebanon who were at risk of dropping out of school and who were being forced to getting married early. The program I worked on involved weekly field visits in the first stage, then daily training sessions for 2 months in the second stage. I was mainly involved in the first stage, but I know that most of the programs that deliver services to refugees in Lebanon depend on physical presence and interaction. Since October 2019, Lebanon has been experiencing political unrest and dire economic conditions. I'm no longer there, but I know that the situation was exacerbated by the COVID-19 pandemic. I can imagine how the beneficiaries of these programs are no longer able to access the services they need, and how the outreach and implementation of organizations working in the field has been drastically affected. At the same time, I know how both the refugees and the organizations are resilient and have managed to come up with innovative strategies to continue working together despite the circumstances. I guess this is an integral part of working in the humanitarian sector. Not only do we have to cope with the crises, but we must swiftly come up with new approaches for our work to continue. That being said, this webinar is held as a part of the streaming IWAC 2020 series on sexual and reproductive health and rights in the humanitarian development nexus. In today's webinar, our panelists will share innovative strategies on reaching and working with very vulnerable populations in humanitarian settings. We have 3 presentations about programs that took place in Sri Lanka, Myanmar, and Ecuador, and focused on young people, LGBTQIA+, sex workers, and people with disabilities. The first presentation is by Dr. Harischandra Yakandawala and Ms. JPT Sachinthani. Dr. Harischandra is a humanitarian consultant with FPA Sri Lanka, which is a member association of IPPF South Asia region. Previously, he worked as a medical doctor in the organization. Ms. Sachinthani is the Senior Manager Outreach, FPA Sri Lanka. Sachinthani is in charge of managing humanitarian programs within the organization. Dr. Harischandra and Ms. Sachinthani, please tell us about your experience working with persons with disabilities in Sri Lanka.
Hi, I'm Dr. Harish.
Hello, I'm Sachinthani from FPA SL. Can you hear me?
We can hear you.
Hello everyone. Here we are presenting this webinar on piloting the IASC Disability Guidelines in GBV prevention and response activities in Sri Lanka. Mainly, Zainab, can you pass the screen for me? It's not working.
If you press the space bar, it should go to the next slide. Or I can share the presentation if you'd like. Yeah?
Yeah, good.
Okay. This is the time of COVID where we have to learn all the different ways to do this. All right. Okay. Can you see?
Not yet.
Not yet.
Yeah.
Okay. Yeah, I'm starting with the UN Convention on Rights of Persons with Disabilities in 2016. The definition of persons with disabilities. Persons with disabilities include those who have long-term physical, mental, and intellectual disability, which in interaction with various barriers may hinder their full and effective participation in society on the equal basis with others. And also with the IPPF Strategic Framework 2016 to 2022, we are aiming all people are free to make their choices about their sexuality and well-being in the world without any discrimination. And also as a member association of IPPF, FPA SL also aiming a country with access to sexual and reproductive health for all, according to the FPA SL strategic plan in 2016 to 2022.
Next slide.
Next slide, please. Can you go to the previous slide?
Objectives?
Objectives. Yeah.
No.
Okay.
In 2016, 2018, funds are open up to Australian aid funds are open up to pilot disability guidelines, IASC guidelines on disabilities to WRC, Women's Refugee Commission, and this pilot aimed to demonstrate and document how GBV guidance can be practically applied to the support and protection of environment and empowerment of women and girls in humanitarian settings. As IPPF member association of Sri Lanka, FPSL was awarded this WRC funding to pilot Interagency Standard Committee guidelines on disability in early 2019. FPSL conducted this pilot study together with the DOJ, Disabled Organization Joint Fund, which is umbrella organization functioning all over the country as DPO, and targeted a cross-sectional study of government officials in health, social services, disaster management, women and child affairs at district, divisional, and community level. Within this pilot study, it is contributed to identification of GBV risk and barriers of PWDs, person living with disabilities, and strategies and strengthen capacity of GBV service providers on disability for inclusive service provision, and also enhance coordination and referral systems. Can you move next slide? Our pilot location is Kalutara district, which is located in Western Province in Sri Lanka, and also highly disaster prone area and geographically diverse. One side open up to the coastal area and also other side connected with hill, country hilly areas. Rural, urban, and state three populations also living in within district, and poverty and other socio-economic disparities are remaining in Kalutara district. As livelihoods of communities, tourism, agriculture, and fisheries, and also plantations can be identified within this Kalutara district. Can you move to next slide, please? The methodology of this pilot study, we use several focus group discussions and observation visits in the community and needs assessments of both person living with disabilities and also service providers, capacity building workshops, consultative meetings, community engagement activities, and review meetings also. Can you move to next slide? As a result, we have gaining from this study, participated majority were female, visually impaired, in age 19 to 59. Among those who participated, persons with disabilities. Within this study, we observed that women-led organizations, especially DPOs focused with women, is very less functioning or not functioning in areas. Some organizations are only registered but not functioning. Women-led organizations are very less. We observed them, and also we were able to facilitate cross-sectional dialogue between the different sectors, government officials, including health, disaster management, social services, and other women and child affairs and other sectors also. Within this study, we observed that among the participated service providers, only 3% have not received any training on disability inclusive service provisions in previously in their professional life. And also above 16% service providers at least heard or managed one GBV case during their professional life. And also 14% at least heard or managed one GBV case during their during emergency. Among the participated service providers, we conducted several capacity building workshops. Within these capacity building workshops, 55% were broadening their understanding on disability inclusion, and also 71 service providers broadened their understanding on managing sexual and gender-based violence in emergency. Those are results we have identified within this pilot study, and post-evaluation with questionnaire was conducted in within this pilot study. And also we demonstrate that with the community engagement activity, the participatory activities can be enhance or improve the productivity of disability inclusion service provision in GBV prevention. One of village surveillance society engaging with this activity, and they have designed a safe shelter with gender and disability inclusive with their members and persons living with disabilities in their community. They developed this design. Can you move to next slide? Lesson learned within this study. Groups of persons living with disabilities, especially in intellectual disabilities, have high risk of GBV in emergency because our systems sometimes not accessible to all types of groups of persons with disabilities, and also some of our early warning system preparedness activities, they are not accessible or not invited to them. So these people can be excluded and also at highest risk in GBV in emergencies. And also inviting to them to the table and consulting with them was important and very effective way to know what works and how for them in emergency GBV prevention. And partnership with local PWD persons living with disability organizations was instrumental. It means actually sometimes in community level, that is only platform they have to participate. Local DPOs are only the platform they have participated. So within this existing resource using, we can do the things in GBV prevention or our other programs effectively and productively. And also facilitating women-led DPOs, especially investing and facilitating these women-led DPOs is very critical need when we are preventing GBV in emergencies, which is inclusive with disabilities. And coordination and referral could be strengthened by multi-sectoral participation of service providers such as health, social welfare, legal and protection service providers. And mainstreaming protection is highlighted as the critical need of disability inclusion. Most of time we are observed that some DPOs are doing their works and programs with the intention of charity, but we need beyond to that right-based approach and motivate and empower persons with disabilities to participate in activities in GBV prevention emergencies actively. That is very critical need when we are doing inclusive service provision in GBV prevention. Can you move to next slide? Recommendations. Within this study, we made some recommendations. First one is promote participation of persons with disabilities, especially women, because women-led organizations are very rare. And opportunities in sexual education for PWs and caregivers is very essential, because sometimes we met several persons with disabilities. They are delivering or receiving sexual education training as first time of their lifetime. They are not received such kind of training previously. So that is gap in our SRHR field. So sexual education for persons living with disabilities and also caregivers, especially in intellectual disabilities, the caregivers are important to educated or awareness on sexual education to preventing gender-based violence in emergency situation and also stable situations. And upgrade capacity of DPO on SGBV prevention. Especially, there are a lot of organizations focused on disability inclusion, but we can mainstream within their, if we can mainstream within their programs or works, SGBV prevention is main part. It is very important. And also, GBV DPO can work in emergency preparedness, also very critical need, because sometimes the people living with disabilities are excluded from the systems. So preparedness activities with the participation of persons with disabilities is important for inclusive service provision during emergency situations. And advocacy for sexual and reproductive health rights of persons living with disabilities within mandates and action plans of disabled person organizations, health sector NGOs is essential, because we met sometimes women and girls within the family even, their sexual and reproductive health rights are not believed by family, even the family. They not believe the people living with disabilities also have sexual and reproductive health rights. They also have sexual desire. They have right to sexual and marriage life. Those things are sometimes not acceptable within family even. So advocacy activities for sexual and reproductive health rights of PWDs also needed within inclusive service provision and GBV prevention. And in-service curriculums of government officials such as health and disaster management, with their trainings, the disabled, how to provide the service, disability inclusive service provided is very essential, because sometimes they not received any training to how to deal with persons with disabilities, and sometimes they are not provide services because they have not capacity to do that. So the include disability inclusive service provision into the training workshops and their curriculums is essential within the pilot also. Can you move to next slide? Next one is allocate disability inclusion budgets for government agencies. Most of times, disabled persons living with disabilities are not invited to the programs conducting by government, and also they have barriers to come these programs because they have a lot of economic problems, and also once they are participating to the program, their daily earning is lost. So these kind of things are barriers to participating persons with disabilities into the awareness and other programs conducted by service providing institutions. So the inclusive budget also needed for these programs to allocate adequate incentives for the participation, and also designing institutions accessibility for disabled persons when they are coming to get a service. The premises should be accessible for all types of disabled person. So this
Sachinthani, I'm going to have to ask you to wrap up quickly so that we can move to our next panelist.
okay. So this kind of budget allocation is needed within these activities, and also disability inclusion audits before the constructing government agencies and other institutions is needed, and also establish a cadre of sign language interpreters. This is the main barrier of communication of the peoples with hearing difficulties when the emergency times and also stable times. If the urban area sometimes available with sign language interpreters, and rural and estate areas it's very rare. So establish this kind of card within the government system is needed, because when they are doing prevention activities of SGBV and providing services to the survivors, in both these actions, the sign language interpreter service is needed. And upgrade government hotlines as accessible to the person living with disabilities also needed, with sign language interpreters and other appropriate communication channels, and consideration of segregated data collection dissemination. This is some kind of mapping at community level to national level, the data disaggregated by age, gender, and types of disability. This can be helpful in preparedness, emergency preparedness activities, and also program designing and response also. Can you move to the next slide?
I'm afraid that we're going to move on to our next panelist for the sake of time. Thank you so much for your presentation, and we will take questions at that. So our second panelist is Dr. Thet Phyo San, who's the Country Program Coordinator and Principal Investigator at Myanmar Youth Stars. Dr. Min, the floor is yours.
Yes. Hi, everyone. Greeting from Myanmar. I am Dr. Min, working as a program coordinator from Myanmar Youth Star Network. Next, I would like to share about the peer education program implementations for young populations in Myanmar. Next slide, please. So this is the rationales of our program. We observe that HIV burdens in conflict-affected areas is very high compared to the other regions of Myanmar. So as you may know that HIV is concentrated among key population as per number of prevalence presented in this slide. Surprisingly, 50% of HIV new infections occurs among youth. In addition to HIV, young population facing SRHR issues such as stigma, violence, and discriminations, unsafe abortions, and barrier to access information services, and also their lack of youth-friendly services. Next slide. So UNFPA and Myanmar Youth Star decided to implement this peer education program. And before I go to the further slide, I would like to present, share about our organization. MYS is a national network for young populations. We work for the young MSN, young sex worker, young drug user, young people living with HIV, aged between 15 to 30. And we closely working with more than 1,500 members across our country for their rights of HIV and SRHR. Next slide, please. Our main objective is to design community-friendly and innovative peer education program to disseminate most relevant message to your YKB based on the international technical guidance for CSE and to create demand for SRHR services. Next slide, please. We target the Yonki population aged between 15 to 30, and we selected 3 townships in the conflict-affected state as shown in the maps. Next slide, please. The figure showing about our program design. Firstly, we conducted a focus group discussion with Yonki population. Next. And we identified the 12 themes of SRHR gaps. Next, please. Next. And then we developed education aid tools and piloting those, pilot testing the education aid tool. After that, in June 2019, we start the implementations of the BI education program. Next. According to the FGD findings, we found that common information gaps such as safer sex, GBV, SRH rights, scale include like communications, negotiations, and other social knowledge such as HIV, STI knowledge. We found that YKB have different preference regard to the communication channel. However, commonly all the YKB like peer education approach. Next slide, please. So after that, we developed the education aid tool. We tailor the CSE message based on the needs of the Yonki populations. And then we developed animated short video clips. So the video, we need to make sure the video will not take time to track the Yonki populations. The topic include as shown in the presentations. And then we tested the videos. After that, we also received the feedback. The animations need to be user-friendly and the message need to be user-friendly. After that, we revised the video. And then we developed the discussion guides and frequent asked questions as well. So next. So this is the discussion guide for the peer educator. We provide both soft copy and hard copy. And next. Sorry, and also we put like animated video clips inside the tablet. After that, we start implementing the peer education program. We start with the process application forms and peer educator selections. After that, we selected the candidates and then we provide TOD trainings. And then when peer supervisors supervise the different groups of the Yonki populations, as shown in the figures, and then we start conduct the peer education session at the township level. Next slide, please. So this is the activity photos. Next. So we provide the TOD at 3 townships, as you see in the photos. Next. So as a result, we train the 32 peer educators and 3 peer supervisors. From the 3 men piloting the project, we finished 222 YKP completed all the education video clips. And also we found that the capacity of the peer educators and peer supervisor began improve, especially in their engagements and leadership skills for the YKPs. Next slide. The slide showing the result. These are the SAN testimonies reported by Yonki population. So as you see here, a young female sex worker, after we educated with the video clips, they realized that the GBV cases meant their community, and also young transgender women said negotiations is co-needed, and also the young drug users said as our program providing at their preferable place, so they don't need to going outside to get the education. So they really appreciate for our program. Next slide. And also we found that behavior change such as sex with condoms, and they improve in their healthcare seeking practice like voluntary HIV counseling and testing, and also other services. Next slide. So the voting showing the peer educator conducting the peer session at the township level. So as you see here, this is the this is the beauty salon. So they provide the education at the preferable place and also time. Some peer educator need to conduct at the time, especially for the MSN group. Next slide. So we also did monitoring and on-job training at the township levels with our head office. Next slide. So next slide, please. So the program is still continue in 2020 so far. We expand the additional township in Yangon because Yangon is a very crowded place and there are many young people population in here. And we also make adaptation based on the piloting experience, revising the training curriculums and included the soft skills. And also in the COVID context, we have adapted a lot of the reprogramming, such as we conduct the online peer education sessions. We utilize the Facebook Messenger platform. So, and also we moving beyond awareness raising to support referral for services, including advocacy work with the survey providers. Next slide. So as the lesson learned, we found that GBV context is highly demanded by all groups, and also separate sessions for MSNs and DG is recommended because these two population is they having different needs. And also videos can stand alone or facilitation guide can support the dialogue when the peer educator had more formal opportunity for engagement. And soft skills and refresher training are needed for peer educator, and also need to provide other essential knowledge such as PrEP, U=U, self-testing, and also preventions of mother-to-child transmission. So these are the main topics when our sessions conduct. And also next. Yes, we found that the use of video clips is a good way to share message easily, and also it is youth-friendly and remain relevant and convenient even during COVID pandemic, because we easily quickly adapt our program. We utilizing the messenger platform, we sharing the video clips firstly, and then we let them watching the video clips, and then we start the discussion via messenger. Next slide. And also in the humanitarian context, this process remain active as long as telecommunications are available. The resource can be easily shared even if the movement are limited. We recommend that integrated services are required. It would be great if we can provide like one-stop services, and also need to sensitize the service providers and to let them know how youth-friendly nature as well. And as a sustainable approach, incentives require to retain the peer educator. But when we set the incentive, it also important like non-financial incentives, like capacity building, because we also found that most of our peer educator became motivated when we provide them a lot of capacity building as well. Next slide. So this is the, yes, it's already finished, yeah. Next, yes. So this is the last slide of my presentations. As a conclusion, we found that the medians of videos and peer education approach were most effective, and it is adopted for the young people population with the animations success, and tailoring key messages based on the needs of the young people populations is critical. And another one is community-led approaches is vital, because as the program under the leadership of young population-led organizations, and it builds trust among their community, and it is a sustainable approach in the future as well. And this type of intervention is feasible and well accepted by young population. Next slide. So we would like to acknowledge UNFPA for technical guidance, UGREF for fundings, and ULEAD for project expansion in 2020. And also, we really appreciate the organizer to let us show our work in this very valuable conference. Thank you.
Thank you so much, Dr. Min, and it's great to know that your program adapted quickly with the pandemic, since it was already virtual and depended on technology. We have some questions directed to you, but we will leave them till the end. So I will move now to our third panelist, Mr. Diego Nardi, who is a Brazilian lawyer and a humanitarian worker, currently working as an associate protection officer for UNHCR in Ecuador. Diego, please share with us your experience.
Hi, hello everyone. Thank you. Good morning, good afternoon. So I will briefly present to you our experience working with LGBTQIA refugees and migrants in Ecuador. I will quickly share my screen. Let me. Can you see my presentation? Yes.
Yes.
Yes, great. So I will try to briefly share with you what we have been doing in the current context of the COVID-19 pandemics on the work with LGBTQIA refugees and migrants in Ecuador. Just a brief introduction on our context. We are a country in South America. We have two major situations we work with. One is the Colombian situation, who has been over 2 decades, a continuing flows of refugees to Ecuador due to armed conflict. And now we have an influx of Venezuelan refugees and migrants due to the social, economic, and political situation in the country. We have approximately 500,000 persons of concern to UNHCR in the country, as our latest figures in 2019. And one of the key populations we have identified among both Colombian and Venezuelan groups are LGBTQIA. They mainly run their country due to violence by armed groups towards them, especially in border zones where armed groups are present. What we call a social control of this group over these areas. They focus on these populations, and unfortunately they need to leave to save their lives. And we have also identified that approximately 10% is figures by UNAIDS. 10% of population live with HIV in Venezuela have already left the country due to the impossibility of accessing treatment. And one of the key populations we work with is LGBTQI populations live with HIV. Unfortunately, due to limited resources, we do need to focus on some specific groups within the LGBTQI population, despite we try to mainstream across our programs inclusion of these groups, but we mainly focus on LGBTQI populations living with HIV and those working with sex, with the majority of persons we are assisting being transgender women. So in May this year, we did some community consultations to understand how the lockdown measures in Ecuador impacted our population of concern, refugees and migrants. We interviewed almost 300 persons, include LGBTQIA refugees and organizations. And our main finds were the following one. We identified that those persons who arrived in the country less than 3 months before the beginning of the emergency were being more affected due to the fact that they were not integrated into local social networks. And this was especially the case for LGBTI refugees. And what we identified as was that those who were part of peer community networks were being able to cope in a better way with the limitations they were facing due to the emergency, while those who were alone were facing much more difficulties to meet their basic needs. Those living with HIV, they report the difficulties to access the ART treatment, the antiretroviral treatment, and also a lack of access to information where they could get tested, where they could get access to health service, voluntary counseling. And They also report the assistance being delivered by local authorities were not considering LGBTQIA population needs and specificities. So based on this information, what we have been doing in Ecuador is basically, we have been very lucky that since the last year, 2019, beginning of 2019, we have taken a voluntary decision to closely work with community-based organizations working with LGBTQIA populations. Most of these organizations didn't have an expertise on working with refugees and migrants. So what we have been doing the last year was to develop their capacity so they could include these populations within their existing programs and supporting them to strengthen their capacity. So for example, in the case of LGBTQI networks, we have been financially supporting them to regularize themselves so they can formally apply for grants, they can formally receive assistance from government and other funding sources, while channeling our assistance through them. So basically, for example, in the case of transgender women, we have been closely working with community leaders, transgender community leaders. They do identify those at higher risk. They share the information with UNHCR and partners, so we can better focus our humanitarian assistance, especially cash-based interventions for these populations. For you to have an idea, from March to June, we supported over 1,500 LGBTI refugees, and 83 persons were supported on access to ART through our partners in Ecuador. We have also been working with the Public Defender's Office. It's a government institution of public lawyers that support refugees and migrants to access migratory pathways, regularization pathways, the asylum system, health services, housing. We have been delivering weekly trainings for them on how to better work with these populations so they can better identify their needs and guide them with their challenges. So one challenge we have been identifying in this current context is that we have been facing a lot of evictions, and LGBTQI population have been disproportionately affected by this due to homophobia, transphobia, biphobia. And what the Public Defender's Office have been doing is supporting these persons to access the justice system so they are not evicted unlawfully. And the owners, they do respect the guidance issued by local governments that evictions could not be realized during the pandemic effects. And we have been reviewing in a monthly basis with our partners our assistance criteria to ensure that as the situation changes, the key populations can access our assistance. So, for example, we have been identifying with HIAS, our main humanitarian assistance delivery partner, that certain profiles of LGBTQIA families were not being able to access our assistance due to the time they were in Ecuador. Despite the time they were still among the most vulnerable groups. So we have been changing our scorecards to ensure these populations are able to access these cash-based intervention, food distribution, access to sanitary kits, and so on. And together with UNFPA, we have been reviewing with Minister of Public Health the guidelines on access to health service for LGBTQIA populations. In this current context where in Ecuador we have been facing several limitations to be present in the field, so one of the main entries we have for service right now are the public health services. So we found an opportunity and a need to review the previous guidelines. They are from 2014 to ensure especially the needs of transgender persons that were not well reflected in the previous guidelines are present, and also referral pathways on SGBV are considered within the new framework. And we also have been supporting several LGBTQIA peer support networks across the country, both at the interagency level. So for example, in the HIV working group, we have been supporting a group of youth persons living with HIV, majority of them are LGBTQIA refugees, and they have been actively sharing information on how to access services, rights for persons living with HIV, acting on the public sphere to inform authorities when there is a lack of treatment available for population, or any barrier they identify that refugees or migrants or any other person may face when accessing these services. And right now we directly support 10 organizations, LGBTQIA organizations across the country. These organizations, they have their own support networks. So we create a cascade effect. We have monthly meetings with them, and they have direct contact with focal points, field office and partners. So we have a very straight communication line with them, and whenever they find a very vulnerable case, both at border areas, city areas, rural areas, we can quickly activate our networks and ensure these persons are safely referred for assistance and services. And here are some pictures of the work we have been doing. This first association at a coastal city, Manta in Ecuador, with a very high population of LGBTQI refugees. They mainly work with transgender women working with sex. They have been a key actor in this context by identifying persons with a higher risk that can access our service, channeling assistance, and also supporting youth networks that have been sharing key information, have been doing online activities on sexual and reproductive health and rights, and supporting for community leaders, capacity building sessions on negotiation skills, on peaceful coexistence, peaceful communication, rights of LGBTI population in Ecuador. And together with Ministry of Public Health, we have been distributing personal security equipment for persons at higher risk, especially transgender women working with sex, condoms, lubricants, and information material on where to access SGBV prevention and response services, as legal abortion services, among other services. And this last picture, it's from the National Network of Sex Workers. This is Karina Bravo. She's a major leadership in the country. And based on the materials we have been providing to them, together with other organizations such as UNFPA, they have been doing an amazing outreach work that unfortunately we are not being able to do due to the lockdown measures. And if I could summarize like key recommendations in this context to work with these populations, we've seen that the working with community-based organizations, it's key. They have maintained the presence in the field. They manage communication networks through WhatsApp, Facebook, and by person that we can mobilize to identify persons at a higher risk. They can support us to reach those persons who are not accessing our services in the current context. And by strengthening these organizations, we are allowing them to develop improved coping mechanisms to the current situations. They have been supporting each other by sharing resources such as food, such as receiving newly arrived persons in their spaces, and ensuring that persons who have not been regularized are able to access regularization services. And I think I've reached the 8 minutes, so I will stop here. Thank you.
Thank you so much, Diego. And as we see from the 3 presentations and from many other presentations that we attended, that localization is key. Working with the local partners because they know the context, because they can reach the beneficiaries and they can tailor the program to their needs is key, and it's a theme that emerged from the three presentations that we watched now. So we have 6 minutes left, and I can see that there are questions in the Q&A section. So there's one question for you, Diego. Can you speak about how you mitigated the stigma surrounding refugees who seek ART?
I'm unmuted. So basically what we have been doing, out of the 10 organizations we work with, 3 organizations are specialized organizations working with persons living with HIV. Luckily, we have been able to form very strong youth networks who have been developing themselves information regarding what does it mean to live with HIV, share information on HIV with key populations, and also with the overall public on this. To allow persons, what we have noticed is that whenever persons are linked with peer networks of other peers living with HIV, they feel more comfortable to access services. So what we have been supporting is community volunteers that work in these three organizations, that whenever they identify someone or someone is referred for them, they follow up with this person the whole process of accessing the nearest health services and doing the liaison for them to access the ART. And what we have been seeing is that the persons who access services with these peers, supporters, community volunteers, they do not face any problem to access their treatment. On the other hand, whenever they show themselves on a voluntarily basis, it happens that they will not be able to access the ART. We have a very close collaboration with the Ministry of Public Health, and we have been forming these cases for the Ministry of Public Health. They have been taking very quick action whenever there is a health center where a case of xenophobia, for example, or discrimination against the LGBTI population living with HIV happens. And we have been supporting them to deliver trainings for these networks, so persons can feel more comfortable to access them. But basically, summing up, the strategy we have been adopting of supporting community volunteers, they often are LGBTIQA refugees living with HIV, that support other peers to access services, has been showing very good results. Thank you.
Thank you, Diego, and thank you, Dr. Min, for answering the questions in the chat and in the Q&A. I see that there's also a question about sharing the different presentations. Yes, the presentations and the recording of the webinar will be shared by email. There's another question for you, Diego. What are the main challenges working with these LGBTQI population?
I think if I could say some key challenges is, in our context, Latin America, LGBTI phobia, it's a very central issue. Violence against this population is very high, and often partners, there is a lack, both by government, humanitarian sector, and civil society, a lack of awareness on the key needs and challenges faced by these populations. It's not uncommon to face resistance by some key actors on the work with this population, and due to the violence that it's widespread across our region, and unfortunately Ecuador is not different. Sometimes it's very hard to enter in some localities, so we must be very creative on how we address these topics. On the other hand, we are very lucky that civil society is very strong, and we have plenty of LGBTQI organizations. They have a very large experience working with this issue in the region. And more we have young networks that we can work together with, and they can share the message with us. They can do trainings with us. They can start their own projects, and this is what we have been mainly supporting. Supporting local capacities should be strengthening and also investing a lot on Pacific coexistence initiatives where people can get to know what are the realities of LGBTI population. So it's not just an acronym, it's not just numbers, so they get to give a face for these populations, these stories, and hopefully they are sensibilized. That's it. Thank you.
Thank you so much, Diego. We have 1 minute left. I'll ask a quick question to, oh, there are more questions. So yes, there's another question for Dr. Min. If there were privacy concerns around using online platforms like Messenger, would you like to answer that live this time, Dr. Min?
Yes. Thank you for the questions. So for the Messenger, we especially approach through the peer-to-peer. So if the young MSN, our peer educator, they contact each other through the Facebook, and then we make sure about the informed consent, because during the COVID we also start developing the online manual guideline for the peer educator, such as promo message and also do's and don'ts for the online course, and the informed consent form if they are joining our sessions. So I hope my answer will answer. Yeah. Thank you.
Thank you so much. So the key themes that emerged in the webinar is multi-sectoral coordination, localization, involving the community, and leaving no one behind. I would like to thank the participants for joining us and enriching the discussion with their questions, the panelists for sharing their valuable experiences, and IWAG for organizing and hosting this webinar. As we said, we can share the recording and presentations with you by email. So thank you so much, and have a good day, afternoon, or a nice evening wherever you are.
Thank you.
Thank you, everyone.
Bye.
Thank you. Thank you.
Thank you.